Okay, chapter 2 of your textbook concerns the chest. Remember, anything we do in the thoracic cavity and the abdominal cavity, so chest or abdomen, does depend on body habitus. Sthenic is the most common type of body type. Hypersthenic is broader, and you can think of everything as more maybe stretched from side to side, versus an asthenic patient where everything's kind of stretched top to bottom, and hyposthenic where it's not quite sthenic, but it's not quite asthenic either. Sometimes you can guess about these things pretty clearly based on, the appearance of the patient, but sometimes these things will surprise you after you take an x-ray, but it's important that we adapt to body habitus and where organs are for patients. So let's talk about a PA chest x-ray. Here's a good example of a person set up for a chest x-ray. Their chest is against the board because this is a PA projection. We can see this vertical shadow line here is lined up with MSP, which is usually aligned with the spine. And this horizontal shadow line here is at the level of T7. We want to put that central ray there. So this centermost part here at the level of T7. So first we need to remove opaque objects, clothing artifacts, long hair fasteners, and long thick hair on top of that. Try and get it out of the way. Long earrings, and then any leads that we could possibly control. This can be found on page 88 of the textbook also, all these instructions, but we use a larger IR. If you're using direct digital systems, this may be your only option, but if you're using a computed radiography system, you may have options, so be sure to choose the large one. Large CR plate. Usually we do it portrait or lengthwise with the body, meaning that we use the long part of the IR, 17-inch length, along with the long part of the body, which is superior to inferior. We want to put it in the bucky, or at least use a grid if we're on a mobile exam, and our SID is 72. The further away we get with our x-ray source, the further away we get from the IR with our x-ray source, we can minimize magnification, which is a kind of distortion. We want to make sure to shield our patient, immobilize. That's probably going to be with breathing instructions, but it can also be by asking your patient to hold on to the board, almost give it a hug. You want to do this exam upright whenever possible. Feet should be equal distance and pointed straight forward to prevent any rotation. The mid-coronal plane should be parallel to the IR. Please, if that's not quite clear by trying to visualize it, please talk to your lab instructor about exactly what that means. Top of the IR should be approximately 1.5 to 2 inches. If you are in positioning lab, please be sure to measure the width of your fingers. For example, mine, if I measure 3 of my fingers together, the width of them is 1.5 inches. So I use that as a real quick reference to see if I have the top of my light, top of my IR, 1.5 inches above the top of the shoulder for a chest x-ray. You can also measure 7 to 8 inches below C7 or the vertebra prominence, or palpate for the inferior angle of the scapula. Any of those should kind of line you up with T7. Make sure that vertical shadow line that we talked about earlier, that's MSP. And again, this is lined up with T7. Chin up, rotate shoulders forward. We're trying to get anything and everything we can out of the lung field. Here we're counting ribs, so this should number 1. Let me pull up my pen here. If we followed it, we see number 1 starts up here and comes down. Number 2 here starts up here. We follow it down there. Number 3 is here. Follow it. Okay, then number 4, 5, 6, 7, 8, 9, 10. We did do that in class as well. Try to take the x-ray on full inspiration. Give clear, concise instructions. If it's somebody who can't take instructions, remember, you might have to time your exposure. We did talk about that a little in class. And we can see the big difference between expiration versus inspiration and how much more information this can give you. All right. Now, this is one way to do it. You'll see in lab to find T7, also where the inferior angle of the scapula, that's what they're trying to show you here. And also if we just measure 1.5 inches of light above the top of the shoulder, we can do it that way as well. Let's see here. There's some anatomy to identify that we'll work on in anatomy class. Sorry, the scroller on my mouse is not working correctly. And here's a quick overview of anatomy. Please take a look at that. Remember that mass in kVp should be at about 100 at 5, 100 kVp at about 5 in mass, but this can absolutely change depending on body habitus. To demonstrate pneumothorax, we do an inspiration and expiration pH test. I wanted to put that in there just as an example of how sometimes, depending on pathology or patient condition, we do have to alter the way we do things. So it's incredibly important that we as radiologic technologists are very open-minded, we critically think, we're adaptive. Nothing or rarely are things by the book. So it's important that we adapt to each patient and each situation. Emphysema patients, we need to drastically reduce technical factors, and we'll talk more about that in pathology next semester. Reasons for upright chest: it allows the diaphragm to move further down, just purely and simply using gravity. It helps demonstrate air fluid levels. For this one, I want you to quickly imagine a water balloon that's half filled up with water, and then a bunch of air got in there, let's say, has air at the top and water at the bottom. Say you put that gently set down that water balloon, and say you're standing up and you're looking down at it on the floor. There would be no way to know how full of water it is. You could probably see that there is water in it, but by just looking down at it, you won't be able to tell. Now, if you got down on the floor and looked at it from the side, you could see its horizontal marking of where the water ended and the air started. That's the exact same thing with a chest x-ray. When they're upright and we have that horizontal x-ray beam, we can see that horizontal line of where there's fluid and then where there's air in the lung. It also, by being upright, prevents engorgement of vessels, again from gravity, and just things filling up in the heart and great vessels. Here's a good exercise on counting ribs. We can do that together in class. Trying to keep this video short though, because I know it's hard to watch really long videos. Be sure to shield your patient on this exam. Always use your markers. Anatomical side must be on the correct side. And finally, I'm going to end it with a note about x-rays as legal documents. We can sometimes be the reason an x-ray might get thrown out in a court case. Maybe somebody had a terrible accident, had to go to court to try and get, get back some money that they had to spend on medical treatment, let's say. And let's say that our x-ray was part of their treatment and now they're in court. If we have any sort of post-processed, like computer marking, say we covered up this left marker because it was wrong and we put a right marker over it, that could be the reason that they throw it out in court. And that could be the reason that a person doesn't get a return on money they spent on medical care that they had to get. Maybe they were the victim of an accident or something like that. So these are legal documents, and when we use the computer to mark our images, those legal documents can be thrown out.